Welcome everyone, and thank you for joining us. My name is Carver. I am a clinical application specialist here at Oculus. Welcome to tonight's clinical webcast, Case Studies and Best Practices for Myopia Management. You have a text box on your GoToWebinar screen where you can enter in questions. Enter your questions at any point tonight, and we'll try and discuss them at the end of tonight's webcast. There will be a recording of tonight's webcast, and you should receive an email with the recording and a thank you for joining us after about a week or so. Our speakers tonight are Dr. Matthew Martin and Dr. Bill Tullo. Dr. Matthew Martin attended the Michigan College of Optometry, graduating with honors in 1999. Dr. Martin has served the mid-Michigan area for 20 years, providing comprehensive eye care, managing ocular disease, and fitting specialty contact lens designs. He specializes in pediatric eye care and myopia management. Dr. Martin has been a fellow of the International Academy of Orthokeratology and Myopia Control since 2003 and is a permanent member of Vision by Design Bootcamp for newcomers. Dr. Martin is also a founding member of Mission Myopia Control, an implementation company emphasizing education and implementation of myopia management in private practices. Dr. Bill Tullo is the medical director of Oculus. Dr. Tullo received his doctorate in optometry from State University of New York College of Optometry, and skipping as many accolades and experiences as an optometrist, Dr. Tullo has a private practice in his hometown of Princeton, New Jersey, where myopia management is a cornerstone of his practice. I'm so excited to learn from both of you tonight, and take it away.
Matt, I'm going to let you take it away.
Excellent. I am very, very excited to be with you folks this evening. And I want to first highlight just how exciting it is for me to be talking with Bill and having conversations with everyone about the importance of axial length, about using axial length in growth curves. And it should be a fun time, and I'm really excited. So let's go ahead and jump off. First of all, the content of this webinar and the opinions expressed are solely the responsibility of me, Matthew Martin, and William Tullo. And we just want you to know that up front. So it's going to be fun. So let's have a good time. Let's first start out talking about myopia management in general. I really love this Gretzky quote, and that is, you miss 100% of the shots you don't take. I think that's absolutely important for myopia management, and it's absolutely important when we're talking about the Myopia Master, because one of the things that the Myopia Master has really done for me is given me the ability to take that shot. It's given me the ability to say, here's information that's actionable, that we can build a plan for your child that maybe I wouldn't have felt comfortable having that conversation. So I want you to remember that you miss 100% of the shots you don't take.
And so Matt, I just want to add one thing to this that I think is really important. It's often easy for the doctor to buy into that concept. The hard part is getting your staff to understand why you're making them do this on every patient, especially every pediatric patient. And I think what I do is I spend time in my office staff meetings, and I always show them cases why, if I didn't have that number, I wouldn't have been able to make that decision. So they really understand the value of the time it takes to get these numbers, which is not a lot of time, but I want them to be invested in saying, we got to get this measurement. And if they don't get it on the first shot, do it again, because it's really important. Doc needs this to make good decisions for the patients.
And I'm glad you brought that up. And we're going to talk more about that later when we talk about protocol, because I think making sure that the staff is following through and getting those measurements is really difficult at times, but it's absolutely worth doing, and it makes it's a huge thing for the practice. So let's talk a little bit about that Myopia Master. I'm sure most of you know this, but some of you may not. The Myopia Master was developed specifically for myopia management, and it does some really cool things. It does axial length measurement, absolutely important. It does keratometry. It gives an autorefraction, and frankly, I like the autorefractor. I use the autorefractor of the Myopia Master, I think is more accurate than the autorefractor that I have as a standalone. So sometimes I'll have a patient, I'll run an autorefraction on them, and I'll say, you know what, even though this is an adult, let's put them through the Myopia Master, because for me anyways, the autorefractor on the Myopia Master does a pretty good job, and I like that. The really key factor here, though, is the progress reports and the risk factor analysis reports. Those are just incredibly important, and they're just a huge part of what makes this combination instrument so incredibly useful. And Bill is going to speak a lot about that tonight, and I'm going to talk about it as well. So let's jump right into some of that stuff. So the Myopia Master is absolutely going to be your partner during the consultation, because parents, I have found, I have a lot of engineer parents in my area. I have a lot of scientific people. I'm near Dow, one of the major centers for Dow, and so I have a lot of engineers, a lot of chemists. Those people love numbers and charts and education. And the more I can educate those people and the more facts I can bring to them, the more successful my consultations are. So for me, being able to demonstrate that a child's axial length growth is either speeding up or slowing down is absolutely precious and incredibly important for those consultations and for those conversations where I want to take a patient who might be a good patient to absolutely being a patient who we're going to be able to work with and the parents are going to be on board. So I'm going to mute myself and let Bill speak a little bit here about the patient education component. Bill, do you want to take it away?
Sure. I think the key to successful conversions and getting parents to understand is to simplify the terminology. And one of the things that parents are very familiar with are growth curves. When they take their kids to the pediatricians, they see growth curves on height, on weight, on all different factors of their child. So they're very familiar with that, and they know what it means to be a standard deviation above or below, behind. So they get it visually. It's easy to understand. So the growth curves are really important, so we can show the relative risk of this child progressing, whether they're emmetropic or they're already myopic. The growth curves are really important. The other key thing from the Myopia Master are the myopia reports. Since I've been using the myopia reports, it's very typical in my practice for there to be only one parent present at the consult. And historically, that would mean that the other parent would be calling the office the next day to get clarification on things. These myopia reports are fantastic. They've cut down those secondary phone calls from other parents that weren't present at the consultation down significantly. So I make sure that every parent leaves with these curves and with these reports, because it's very simplified, and it gives the parents, it allows them to go home and explain to the other parent exactly what's going on and why they're not getting traditional glasses this year, and they're getting some other kind of myopic care.
Did you want to speak on this atropine slide here, Bill?
Sure. This is just a case of a child that was put on 0.01% atropine. You can see the growth curve is a very steep curve, and the gray area shows the beginning of the 0.01% atropine. And you can see that growth curve was barely not affected at all, and the eye kept lengthening. And then it was switched. The green area shows the 0.025% atropine, and you can see a dramatic flattening of that growth curve. So these growth curves were not only useful in the explanation to parents of the problem and the risk that the child has, but also into looking at the efficacy of the treatment. And initially, when the Myopia Master was first released, this was really the only tool we had to look at the efficacy of treatments and to make judgments on whether we alter the treatments or continue the same treatment. But this is our new software, and this is the thing I'm most excited about. And if you already own a Myopia Master and you don't have this software, this is a free upgrade that you can get. And this software is amazing. It uses normative data from thousands of eyes, and it will show you whether your treatment is working. We have the green area where you're getting good control of growth. And all these growth rates are annualized. So even if you don't have a full year's worth of data yet, you still get an annualized growth rate. So you can compare apples to apples. And you can see that the growth normalcy is different at different ages. We know that the eyes grow much faster on younger children and they slow down as the child gets older. And these normative databases accounts for the child's age. And they'll put your child's growth rate in the green, yellow, or obviously red area. And we all want our treatments to keep the child in the green area if possible, and certainly want to avoid that red area. So it's very effective. This is just an example of a patient that was fit with orthokeratology using the standard fairly large 6.2 optic zone, and you can see that it wasn't really perfect control of the growth of the eye. And then they redesigned the lens in the purple area to a smaller optic zone treatment zone of a 5.5, and you can see that the curve flattened out, and now we're getting good control. So it's easy for patients and parents to look at this and say, oh, I want to be in the green, I'm not in the green, or I am in the green, and what do we need to do to keep me there? So the visual is very powerful, makes the explanation to parents simple, fast, easy, and it makes making changes or not making changes easy for them to understand.
I think that is absolutely brilliant, Bill. And I just love the way that they have this set up. I love the fact that you can look at it and say, are they in the green? Are they in the red? Do we have to be concerned? And then where are they at for their age? Later in the discussion today, I'm going to talk about our old protocol, which is very pertinent for those who haven't updated their software. But this software update really conquers a lot of that, doesn't it?
It also takes the math away. My technicians used to have to do all this math for me, and they would put it on a sticky note so I can enter it into the EMR. And now it's all the math is done. There can be no human errors, and the rates are calculated. It's just so much simpler. I never want to go back to doing all that subtraction and addition.
Okay, so I'm going to let you keep talking since you're doing such an amazing job. Tell us what you're thinking on this particular case here.
So this is just a child at about 12 and a half years old, had orthokeratology treatment. And you can see that the flattening of their curve, you can see that their growth rate, the controlled growth rate, is in the green for both right and left eye. So this is a patient, without even looking at any other parameters, that I would feel satisfied that our treatments are effective and working. And if this is time, if a year's gone by and I want to replace their lenses, I feel very comfortable on not redesigning anything and not tweaking anything, and just basically duplicating them and giving them a new pair of lenses. Get all at one glance. I can show the parents, I point to this and look, your child's doing wonderful. They're still 20/20 uncorrected. They're in the green. Their eye length growth is normal for their age. We don't need to do anything except keep doing what we're doing.
I love it. And what about the spectacle lens therapy? What does this one say to me?
Yeah, so this is also an interesting case here. We can see in this case, the 12-year-old patient was given spectacle lens for myopia control. And you can see this patient also, their axial length has stopped elongating. Now, again, this is about a 2.5-year period, almost 3-year period. They've been wearing these spectacle lenses. You can see over that period of time, there's been virtually no change in their growth of their eye with the myopia control spectacles, which I really hope that we're going to see shortly here in the US. Very anxious about these impending approvals.
And then how does axial length, Bill, guide your conversation with parents? Like, you know, how are you using that to like talk about what you're going to do?
So in a case like this, you can see that their axial length is 25, more than 25 millimeters in both eyes. And the patient is almost 14 years old, and they're already a -2 in the right eye, a -1.85. So they're already fairly myopic already. You can see the prediction is if we do nothing, and I always show the parent, look, we can prescribe glasses like we've done in the past, but I want you to know if we do that, the patient, the child is likely going to be a -4 if we do not intervene at all. If we intervene, we have a chance at reducing that likelihood, and maybe they'll be a -250 or a -3. We can't stop the child's eye from growing. We always tell the parents not to expect no growth, even though occasionally we get no growth. We never want to make that expectation, because especially a child who's 14 years old, they're still going to get taller, their eye's going to grow somewhat. So we're going to see some axial length growth, but what we emphasize is we want to see normal growth for their age. We don't want to see the excessive growth that's going to add significant amounts to their nearsightedness.
Yeah, and I think that's a very pertinent point about discussing the fact that we're not going to stop things completely. I still run across colleagues sometimes who will make that promise to patients, and that's always going to be a difficult thing to fulfill because it's just not going to happen. Most of the time, we're going to have some growth, and the goal being to get it within the normative growth for them, correct?
Exactly. I mean, obviously, if you're dealing with a 17, 18-year-old almost adult, the risk of growth is less than if you're dealing with an 8-year-old child, which you're guaranteed their eye is going to grow. So there is a relative risk with the age of the patient, but you're absolutely correct. I don't want to give the connotation to a parent that our goal is zero growth, because it's very rare that we achieve that. In fact, it's almost never occurs. If your measurements are accurate, there's going to be axial length growth just with the normal growth of the eye.
Perfect. Okay, so here's an 8-year-old emmetrope that you've got here on this particular case. Walk us through this.
So the first thing I show the parent is the good news is your child is still 20/20. The bad news is at 8 years old, they should be slightly hyperopic or farsighted. I'll use the term farsighted. And because they're not, their risk of becoming myopic is higher. Now, the good news is your child's eye length is only 23 millimeters, and I point to the dot saying it's below the average for their age. So their risk is not as high as some other child's that have much longer eyes. Nevertheless, at 8 years old and they're plano, there's a good chance that by the time they're 9 or 10, they're going to become myopic. So this is a child I might consider putting on atropine right out of the gate, saying our goal is to try to keep them as close to plano as possible. It may not be possible, but we can minimize how much myopia they develop over the next 10 years.
So what do you think how do you think most parents are going to respond to that, Bill? Let's say that you do this presentation to somebody, and I would agree with you in this particular case. I know this child's going to become nearsighted. How do you present that in comparison to presenting to someone whose kid might be a -6 or 8 or 9 or 10?
Yeah, well, the first thing is I look at mom and dad and see if they're -6, 7, 8, or 9 or 10, because I know the conversation with the highly myopic parent is an easy one. They don't want their child to be like them. They have parental guilt like we all have with our children, and they are very much aware of what being nearsighted is and all the things that go along with it. So those conversations, even with a plano child, tends to be very simple. The more complex one is when they're sitting there and they don't wear any glasses at all, or they only wear readers. And so they don't really understand even what becoming nearsighted really is. And that's a longer conversation and probably a less successful one. I would say that my conversion rates on those parents with those kids that are plano is much lower than on the myopic parents who kind of lived it, know it, and have that parental guilt of giving their genetics to their children. So I still have the conversation. I probably don't dig quite as deep. I will tell them, look, this is what our prediction is for your child. They're going to probably be a -250 if we do nothing, and we can do that. And right now, we don't need to prescribe anything. And maybe I'll say, you know what, instead of seeing you back in 12 months like your vision plan pays for, why don't we come back in 6 months and just check their vision and just do a refraction and make sure they're not becoming nearsighted.
I think that's absolutely important. I think a lot of times we're too hesitant to bring people back. It's not uncommon for me to lay the groundwork for future treatment plans by saying, let's see you in 4 months, let's see you in 6 months. You know, I think that can be very profitable for the office, especially if you're charging for your time. Let's bring them into a refraction, maybe a small office call associated with that, whatever. But a lot of times, the amount of time you interact with those patients really will feed, if you will, the later conversations about wanting to do something about it.
Especially breaking that cycle of the vision care plans. If the patient is a vision care plan patient, you want to start that even before the need for an intervention that's going to be outside of their vision care plan also. So I'm not hesitant at all to say, we need to see you back in 6 months, and this is going to be outside of your coverage, and this is what the cost is, and it's straightforward, and get the parents used to that.
Excellent. All right, well, what about this 8-year-old visit with no correction? There's a significant case. Goodness, this is a much more straightforward conversation, isn't it?
Yeah, well, it's problematic in all kinds of ways. So the 8-year-old kid is in 3rd grade. He's 2400 in the right eye, 2250 in the left eye, walking around with no glasses. And look at that axial length, over 25 millimeters already at 8 years old. So now here's a kid now that's being predicted to be a -8 if things go well and there are no interventions, more likely to be even higher than that. So here, this is a conversation where even if the parents are emmetropic and they don't know what myopia is, this is a conversation. One is I don't want to make them feel bad about this kid's not seeing the trees and the leaves for a couple of years now. I want to make them understand is, okay, it's good that we found this now. We need to do something about it and go through the different options they have. We can do ordinary glasses, but if we do that, here's what's likely to happen. And a child like this, again, we want to talk about contact lens intervention, whether it's a soft multifocal contact lens, or my favorite was orthokeratology. For an 8-year-old like this, they typically will do extremely well. Not a lot of astigmatism, simple, straightforward case. And for me, I seem to be able to control axial length growth better with Ortho-K than any other tools in my toolbox. So I'm going to talk a lot about Ortho-K to their parents. And I would even go out of the gate even before getting a pair of glasses, go right to Ortho-K, as long as the child wants to do it. The other important thing is with orthokeratology or my sight or any contact lens intervention, I have parents bringing kids in that they want the kid to have this correction, and the kid doesn't want to do it. So I make it very clear, and I have a conversation with the kid alone saying, do you want to do this? You need to want to do this. And here's why I think you should do it, but I need the kid's buy-in. Even an 8-year-old, I need the kid to say, I want to do this, because I have found that if the child doesn't want to do this and they're being forced by the parent, it often won't go well. And so I say, okay, if the child doesn't want to do it, I said, okay, how about we do this? Let's start you on some eye drops. We'll get you some glasses. And in 6 months, we'll reevaluate. We'll talk more about this and see how things go.
So you just took the words right out of my mouth. I just started a patient today, came in for a myopia management evaluation. We looked at their growth prediction. We looked at axial length. We talked about the ins and outs. Child has failed with contact lenses, absolutely doesn't want me to touch their eye. So I was talking to the child, I was talking to mom. I said, why don't we kind of back into this from the perspective of, let's put your child on atropine, low dose atropine, and then let's get them used to taking an eye drop for the next, say, 6 months. And then once they're used to having their eye touched, then we can explore peripheral defocus contact lenses, or my favorite, orthokeratology, because the child dances and wants to be out of glasses, but has not been successful touching their eye in the past. So the child said they were very nervous about drops, and I said, Mom, why don't you let me put a drop in her eye? Child was nervous about it. I sat the child down, had them look all the way up, approached from below the eye, so we're not in the visual pathway, put a drop in each inferior sac below the lid. Child handled it perfectly, and I told Mom, I said, I can teach you how to put drops in your child's eyes so it's smooth. Then the child will get used to it, and then in 6 months we'll move them to Ortho-K plus the atropine, or peripheral defocus contact lenses like the MySight plus atropine. Do you ever do that? Do you ever start them with atropine and get them used to touching their eye, and then move them to something where they're actually putting something in their eye, Bill?
Absolutely. What I'll often do is, because we'll see our patients every 3 months to get axial length measurements. So on that first 3 months checkup, if they're doing well with atropine, I'll have my technicians spend 15 minutes with Celluvisc on the finger, having them touch the drop to their eye. So that's like the intermediate step, and then give them some to take home. And then in the 3 months, the 6 month follow-up, ask them how they're doing, show me how good you are at it. And then say, well, how do you feel? Putting the contact lens in is just like doing that. It's not a big deal. And then so we take it a step at a time. Sometimes it takes 6 months, sometimes it takes 12 months. Every kid is different, and the girls do way better than the boys, a lot faster and a lot younger, typically. But in general, I do wean them into it if I know that they're just not ready, whether it's a psychological fear of doing it or they just don't want any part of it. I'll trick them into getting to know that this is not a big deal. You can do this. And oftentimes we make it a challenge. I want to see how many times you can cut your eye with that drop of Celluvisc, and they do it. And for the most part, a child like this really, in my hands, would do better with orthokeratology.
Absolutely. I'm in the same boat as you are. I'm an ortho-K guy, and that's usually my preferred methodology. But if I can back into it by doing atropine and get them used to it, then that's a way I like to go. All right, so this next section is going to have some pertinence, but it's also going to be a little bit outdated. I have to be very forthcoming and tell you that I thought my software had been updated, and because I was a little underwhelmed by what I was getting, I didn't realize that my staff had never updated it properly. So some of what you're going to see in these next slides is now going to be, I don't want to say superfluous, but perhaps a little bit old school now that they've got the software working so amazingly well with those adjusted growth curves. So bear with me. I think this is important to learn, and it's good underpinnings, but some of it has been replaced a little bit with the modern software that Bill was just showing off. So let's talk about change. These are things that we kind of know, but I want to review these with folks anyways. So axial length change occurs faster in young children aged to 6 to 10. Now, we've known that for a while, and we know that compared to older children, 12 to 16. So we know that the age we really want to intervene is young, but we really want to be intervening at all ages. So I think it's just important for us to be aware of that. Growth speeds up 3 years prior to and 5 years after onset. And I think that's really an interesting thing as well, because when you see a child who's emetropic, even if their growth curves look okay, but you can see that axial length growing longer fast, I think you need to be more aware on that particular patient. And then the greatest acceleration is 1 year prior to the onset of myopia. Bill, have you seen that in person historically?
Yeah, and actually, when I first started seeing that, I didn't understand it, and I wasn't familiar with the studies showing that. And then when I read the studies, and I said, "Wow, that makes a lot of sense," because I've seen it so many times. And I'm saying, why are they not myopic yet? They were emetropic 2 years in a row. Their axial length changed significantly, and they're still emetropic. It's like, was my wet refraction not good? No, I think it was pretty accurate. Yet I see significant axial length growth and still the refractive error lagged behind. And I just was wondering, was it some error in my measurement system? But it happened way too often. And now that I've read through these studies and say that is exactly what I'm seeing. And also what you're showing here with the axial length changes, if you look at the new Myopia Master growth control software, you can see that the normative data changes every year as a child gets older. So the growth rates do change with age. And so even though this study is 11 years old already, the data that we're using in the Myopia Master is only a few years old, and it actually supports all this that you're showing.
I have to tell you, I'm really super stoked now about getting that software updated. And I'm a little embarrassed because I thought my staff had updated it before this.
Well, Matt, the software has only been available for a few weeks, so you're not far behind.
So it's going to be really fun to dig in there once we move to the new facility. So I'm pretty stoked about that. So let's talk about our protocol in my office, which is interesting because we talked about this a little bit earlier. I think it's really important from a practice management standpoint that you get your staff used to measuring everyone under the age of 18 with an emphasis on nearsighted kids and kids of nearsighted parents. I would love the idea of running everybody on the Myopia Master, old, young, everything in between. But I know in my office, when we're really seeing a lot of patients in a day, it's difficult sometimes to get Myopia Master on all age groups. I think you absolutely need to be getting everyone under the age of 18 though, regardless of who they are. What is your protocol in your office, Bill?
Yeah, it's very similar. I mean, it's actually pretty simple. I don't have an emphasis on refractive error. Everyone under 18 gets a myopia master at every visit. At the age of 10, I do a Pentacam also, and I'll repeat it at the age of 15 one more time. So my children get myopia master every single time. So I have axial length, and they get a Pentacam just to screen for keratoconus at the age of 10 and at the age of 15 again. So again, my adults all get a Pentacam. They don't get a myopia master. They all get a Pentacam. So the myopia master usage for me is just if you're 18 or less, you're going to get a myopia master every visit.
Absolutely. When I say that there's an emphasis on nearsighted kids, I guess what I mean to say is I'm more apt to go over the results.
Oh yeah, and I agree. I mean, I'm on a hyperope. I might glance at it, but I won't even talk about it with the parents. I had a parent come to me just today in the office and said to me, "Is there any chance we can?" And the kid was +4. I'm like, no. I mean, they heard about myopia management. And they didn't realize that, well, this is hyperopia, not myopia, and they were hoping there's something they can do to help the child. Now, I know that a lot of our colleagues do hyperopic ortho-K. That is not in my tool belt today, but I know there are people out there doing it. But for me, I said I actually referred them to a colleague if they were interested who does hyperopic ortho-K, but that's not something I do.
Yeah, that makes sense. I do a fair amount of it, not as much as I would like, but a fair amount. But yeah, certainly it's not doesn't fall under our myopia management protocol for sure. So what do we do with the information that we're collecting from our young patients on axial length measurement? Do we keep it safe? Do we, keep it secret? No, obviously we're going to want to be sharing that with people because that's how we're going to open these lines of communication. So I'm going to try to simplify. And what's interesting here again is that this has been replaced with the software. But for those of you who don't have the software yet, or perhaps you're using, maybe you have a different axial length measurement device and you're thinking about going to the Myopia Master, because you really should go to the Myopia Master. But let's at least look at what you can do with the numbers, just the raw numbers themselves, okay? So what is progress? When we're measuring, what is progress? What are we looking for? So my rule of thumb, and again, this is going to be replaced with the new software to some extent. My rule of thumb is 0.06 millimeter change in a 90-day period. So if I have a child come in, I measure, they have 0.06 millimeters to change in 90 days. When I extrapolate that over 6 months, that's 0.12, or for a year, 0.24. For most of my patients, that's going to be too much progression. Now, am I correct in saying, Bill, that with the new growth charts, that might be telling you that you don't have to be concerned in a 17 or 18-year-old? Is that right?
Exactly, yeah. And I use the exact same math that you did before I had the software, so I don't feel too outdated. Again, the software is only a month old. It's a new software package, and I was way more concerned, obviously, if I saw this in an older patient, because they should not be changing as much. And I was a little bit less concerned if they were younger as far as the actual amount, but it was very hard to extrapolate, well, how much more concerned than an 8-year-old I am from a 17-year-old. It was just because I didn't exactly understand what the differences were. The normative data now shows me exactly what the differences are at a glance without me doing math. And again, I'm all for trying to eliminate math. Anything to make it simpler.
I'm talking over you here only because I'm so excited to get that software downloaded, because honestly, I crunch a lot of numbers and I'm really kind of stoked about getting that new software in place, because it's hard not to have that. To me, that's what makes the Myopia Master so magical, is the software, is the communication component, is the fact that I can go to the parent and say, your child's in the red, your child's in the green, we have to act on it, we have to watch it. I think that's huge. I think that's one of the things that truly makes the Myopia Master so amazing.
Yeah, to me, I mean, most biometers are accurate, and they're all similar in this fact that they give you a number, and the numbers, optical biometers, they're all pretty good. the difference to me is the software. The software is the parent conversion tool. It's the tool that I can have a conversation that used to take 30 minutes and I can do now in 10 minutes. And the parents will understand exactly, and they'll walk out with knowledge that they can share with their other spouse, and it just makes it so much easier. What used to be a long consult now to me can become really shortened and really clear, concise, and it just saves me a lot of time and effort.
And it makes a big difference on conversion rate as well, I think, because when I'm
Yeah, and conversion rates is everything. Yeah, I mean, even a 20% increase in conversion rates is very significant. So again, conversion rates are so important.
So if we got a child who's already doing ortho-K, peripheral defocus contact lenses, or atropine as a monotherapy, we can often use the progression to decide whether or not we want to add another method. So example, a child successfully doing ortho-K, last axial length was 2450. A 90-day follow-up, the new axial length measurement was 2472. So that's definitely more than 0.06 change in 90 days, right? So for this particular patient, I considered strongly adding low-dose atropine to their ortho-K because I find those things to be synergistic. I think that works pretty well. Do you do a lot of combo therapy on these people who are progressing, Bill?
Well, on the people that are progressing, yes. I mean, but fortunately, it's probably less than 20% of my ortho-K patients do I need to do it. But yeah, when they're still progressing, if I can't tweak the fit any better and get any more control out of just the ortho-K, absolutely do it. The other useful thing is the opposite, is when I have a patient on combo therapy and they're getting older and older, and I'm saying, oh, at some point I'm going to stop this atropine. I can also use this curve to know if stopping the atropine was a bad thing. So it's also, it works on both directions, adding and subtracting.
That's brilliant. That's absolutely brilliant. Are you a fan of 0.01? You and I talked about this earlier, and I think it's almost a discussion for a different day. I'm a fan of 0.05, 0.025 and 0.05, and you're a 0.01 guy, right?
I start, especially blue-eyed patients, I start them off all at 0.01. I tell the parents we're likely going to increase. There are 3 levels of therapy. We're going to start with the lowest, and then we're going to slowly build up as needed, as the growth curves tell us. Brown-eyed patients, I start them at 0.025. I don't go to the 0.01. But I have found in my neighborhood, and the reason I do that in my community, I have several other doctors who put everyone on 0.05. And I have some of their kids come to me because their pupils are huge and they're blurry and they're not happy, and these docs are not measuring axial length. They prescribe the drop and say come back in a year. Woo! And they'll come into me, and so I had so many of those that I work it differently. I make sure that I'm different than all the other practitioners doing atropine in my area. So I have no problem seeing them 4 times a year and slowly building them up if need be. And I have some patients who do well on 0.01%, believe it or not, despite the literature. So I go by the numbers, I go by the normative data now. And again, blue eye I do treat a little bit different than brown eye, because even though they don't always get blur, they do get sometimes really big pupils, and those 7-8 millimeter pupils can really cause some glare problems, especially if the child is a teenager. If they're 6, 7, 8 years old, it's usually not a complaint or a problem. But as they get older, especially closer to driving age, you want to be really careful about what their night vision, quality of vision is.
And I think that speaks again to the progressive, the progression software component. I really think that's the case. I really think that speaks to how efficacious that is. So here's a case of mine. This is a CS case. It's a 14-year-old Indian male, new to our office a year ago. Rapid increase in prescription sent to me by a referring doctor. So cyclo on this patient, -875, -7520, -9.25, -75,135. So the horse is out of the barn already, so to speak. I'm not sure what other better colloquialism I could come up with, but I looked at some options here for this guy. I looked at ortho-K, I looked at atropine, I looked at peripheral defocus contact lenses for him. Bill, you're an ortho-K guy, I'm an ortho-K guy, but what do you think about a -9, -9.25 RX?
Well, I've done a few of these. and I will tell you that there's a couple I regret doing. And I can think of one in particular where his two younger brothers were -4s. I did ortho-K successfully on, and mom was begging me to do the -9 older child in ortho-K because the other two kids were so thrilled and so happy. And after probably 6 months of her badgering me to do it, I with my better judgment, I made the mistake of doing it, and it was just a long, and we actually got 20/20 plano vision, but he was never happy with the quality of his vision. It didn't last all day, and it was just, I mean, probably 15 visits later, it ruined the other 9s that I was actually able to do. It made me not want to go that high anymore. But I have colleagues who do these routinely and do really well with them. But I will tell you, is looking at this case, a 14-year-old, I would probably go right to peripheral defocus contacts with maybe adding atropine also, depending on, again, how quickly this kid must be changing fast if they're in a 9 already at 14 years old.
Yeah, 100% true. And I feel exactly the same. I've done -9, I've done -8. I take them with a big grain of salt now, because honestly, it can be a much more difficult case, especially with sleep schedule involvement as well. So
Yeah.
this particular case, you were right. I leaned on the peripheral defocus contact lenses, and I went with atropine here as well to back that up. Now, what happened? That's the real question. So his original axial length was 27.73, and the left eye was 27.96. So very long axial length measurements, which you'd expect for that high prescription. So 6 months later, we had him at 28.14 and 28.30. So does that meet our newly established criteria of 0.06 in 90 days? And yes, it does. It was 0.41 for the right and 0.34 for the left. So extrapolated over a year, we're going to be a very significant, and again, this comes down to that math again, doesn't it, Bill? We know that this guy's growing way too fast. So I ended up increasing his low dose atropine to 0.05%. That says 0.5%, so that's a pipe there. But I ended up increasing his atropine. Now we're waiting for the results of that, but I will tell you that Bill is right. This patient is not enthusiastic about the halos they're getting right now, especially at 14 going on 15. So
yeah, the bigger thing is when he gets his driver's permit at 16, he'll be even less enthusiastic about the halos.
100% true. 100% true. Let's look at another one. This is kind of an interesting case. This is AD. It's a 6-year-old Asian male. Drove 2 hours, by the way, to our office for myopia management. Now that says something. I just did a recent interview with Review of Myopia Management, and they were talking to me about being a rural myopia management practice in an area that doesn't have a large city center nearby. It is amazing when you specialize in myopia management and when you have instrumentation like the Myopia Master. It's amazing how far people will drive for your expertise. I routinely have people that drive 2.5, 3 hours to come see us. And they'll drive by 10 or 15 or 20 other eye doctors to come see us in our office. And it's because we have the technology. It's because we have the software. It's because we have the things that we do in order to meet the expectations and to deliver expertise advice. So again, I really can't tell you how much I enjoy having the instrumentation to allow me to do that. So cyclo on this young man after 30 minutes, -4.25, -1.25, 180 in essence, both eyes. And as you can already put in your mind, that's a heck of a prescription for a 6-year-old, right?
Sure is.
Axial length on intake was 24.57 and 24.34. And by the Myopia Master, he was predicted to be -10 to 11, maybe as high as a -12. So this child is off to the races, right? And so we know that this is going to be a problem for this young man. So talk to Dad about several options. Ortho-K, my favorite. Bill and I are 100% on the same page. I talked about peripheral defocused contact lenses. I talked about atropine as an option for this young man. So what we ran into with this young man is that basically he was unwilling to touch his eyes or let me touch his eyes. So Dad and I ended up going with atropine to start with this young man. So we started him on atropine, and he recently came in for a 4-month axial length follow-up. So that was, we saw him in June and then to November. He came in to see me in November and he wasn't doing too bad. So he had a small amount of growth in the right eye and a little bit of growth in the left eye, more than I wanted. But when we saw him recently in March, he has significant growth from just 4 months ago. So we know, and again, the new software is going to do a really good job illustrating this, but we know this young man is growing way, way too fast, and that the low dose atropine we have him on is not getting the job done. Okay. So how does the Myopia Master axial length software inform our course of action? Well, we know from the software that we can look at it and say this young man is growing altogether too fast and we're not flattening that curve. When we look at our axial length growth rates, we can see that that curve is not flattening in any way. So do we increase the atropine strength? Do we add PDCs like MySight, or do we add Ortho-K? Bill, where would you be leaning here? -4, 6-year-old Asian male.
Boy, I would love to do Ortho-K. I have found with young boys especially that because of the size of the Ortho-K lens, which is much easier to insert and remove, that I have more success with the, I mean, again, a little bit of anesthetic on the first application of the lens so they don't have any shock of feeling it, and letting that anesthesia wear off as the lens is in their eye and let them feel what it's going to be like and get that gradual sensation. I try to convince them, look, I'm going to put the lenses in your eye for you first. I want you to see what they feel like. You are going to feel them, but it won't hurt. And usually with a 6-year-old boy, with a 6-year-old girl, it's almost a no-brainer. It works every time. 6-year-old boy probably works 60, 70% of the time. But I try to get them aware of what it's like. And if it doesn't go well, again, come back in 3 months and we'll do it again. We'll try it again and we'll slowly desensitize them. And typically we can become successful within a year. And again, the boys tend to be a little tougher than the girls.
And I think you're 100% true. I'm leaning towards Ortho-K. I have Dad coming back at the end of the school year, and we're going to be jumping off with Ortho-K for this young man. And I'm actually quite confident he's going to be successful. He did not let me touch his eye originally, but when I worked with him the other day after having taken atropine for close to a year, he was much easier to work with. So I think we're going to have good success with him, and I am absolutely going in the direction of Ortho-K. Now, I talk to people who use higher strengths than 0.05 atropine, but I just couldn't imagine putting a child on 0.1. That just seems like it would be crazy for me.
Yeah, again, it's certainly outside of any standard of care too, and I'm not comfortable going above the 0.05 myself either.
Okay, so options. Again, increase atropine, add PDCs, add Ortho-K. I am definitely choosing. I don't know if anyone's a movie file, but when I typed in the word choose, I ended up thinking of the poster for Train Spotting. So I just threw this in here because actually the truth is that I actually chose Pikachu. No, I'm sorry. I apologize. I chose Ortho-K here. So you guys know I'm an Ortho-K guy, and that's what I ended up doing. And I'm really excited to see how this kid goes. I think we're going to be wildly successful. But it's going to be easy for me, given the new software, given the growth charts, to say, Dad, here's what we have to do. I need you to help me to get this kid ready to go. So let's move on to the next slide here. I just wanted to note to everybody, I don't know where you guys are on choroidal thickening, but I think it's a really interesting thing to talk about. I haven't incorporated OCT yet into my myopia management, but I may start looking at choroidal thickening changes as sort of an endpoint for myopia management. I don't know of anyone who's doing that yet. Do you know anyone who's integrating OCT along with axial length measurements and along with topography?
I don't, and I haven't seen any papers on quantification of the amount. I mean, I've seen thickening, and I've done some measurements out of curiosity. Don't really know what to do with it, and I don't know how much is significant. But I think there's going to be something in the future that we're going to learn from looking carefully at how much choroidal thickening we're getting, and quantifying that and correlating it with the success or failure rate of our myopia management.
But again, I mean, if we're getting axial length measurements, does it really matter?
Maybe not. It is interesting, though.
It is very interesting. Okay, let's talk about your slides. Go for it.
Sure. We have only 10 minutes left, so I'm going to go through these fairly quickly, Matthew. We have a 15-year-old female who's been using atropine 0.025% for a year. And the question is, if you look at the growth curve, is this patient doing well? And if you look just at the growth curve, it's really hard to tell, at least for me visually, are we successful? Are we not successful? I would say when I look at this, I'm not sure if we're successful. But if we go to our next slide and look at the annual growth rate, we can see here that the left eye is 0.027, which is in the red, and the right eye is 0.18, which is in the yellow. So now I'm saying we're not doing as well as I thought we're doing. Again, having this normative data, and for this child who's 15 and a half years old, I think it really is giving me another level of confidence on whether or not I need to modify what I'm doing. I think in the past, someone like this, I may have left them there without boosting them up, but now I'm going to boost this kid up to 0.05% because I'm not doing as well as I thought I was doing.
If you don't mind my ignorance here, walk me through what you're seeing on this screen so that the people who are listening to us today can hear it from a real expert in the new software, exactly what you're seeing.
Because so what you're seeing are the 4 measurements done every 3 months on this patient over a year period. The left eye is in blue, the right eye is in purple. And so it graphs the curves. Obviously, an upward slope is getting worse. A downward slope would be improving. And when we look at the top here, this is the normative data for that age group. The green being the good area where we see normal growth, the yellow is suspicious, and the red is abnormal, accelerated growth. This is the annual rate here. We see 0.27 for the left, 0.18 for the right. And this is the plot with the standard deviation. So we see the right eye here. The center of the plot is in the upward part of the yellow. In the left eye here, it's in the bottom part of the red. So I can see just at a glance, looking at these 2 dots here, my patient's not in the green. They're not doing well. I need to do something to do better for this patient. So while I may have slowed their growth, I haven't slowed it to the normal rate for their age.
Bill, that is brilliant. That makes so much more sense to me now. And so if both eyes look like the left eye, you might be thinking that maybe
exactly, yeah. Especially, I mean, if they were both in the yellow and there was no change in refractive error, I might keep them at that and go another 3 months. And then the beauty of seeing them 4 times a year is that I'm not going to lose ground quickly. If you're seeing them every 6 or 12 months, there's a risk in 6 months there could be a significant loss of acuity and worsening of their axial length. So I'm a big proponent, and what I do is they see me twice a year. They see me at the annual and at the 6 month. They see my tech at the 3 and 9 month, and my tech will pull me in if there's anything that's not in the green, that's not normal. So the other 2 visits are non-doctor visits, and if need be, they come back and they see me, or if I'm there and seeing patients, they'll put them, say, doc wants to talk to you about this. And so it streamlines our scheduling. So I don't have doctor appointments 4 times a year, only twice a year, but they see us and I get the data 4 times a year. So nothing slips through the cracks.
That is absolutely top-notch brilliant. Thank you for that. All right, walk me through this one.
This is a younger patient, 11-year-old, and they're on my 0.01% atropine. And the question is, are they doing well enough? And so here's again a year's worth of data, four 3-month data points. And we can see here that the left eye, the growth is only 0.18, but it has nudged into in the yellow area. So a young patient like this, they're already a -3 in both eyes or a 25 length. A patient like this, I'm going to convert to 0.025%, even though I started them at the 0.1, and they were told when they started, there's a good chance that we're going to have to boost you to the middle or the higher level. And so it's not a surprise that when I'm sitting at this 1-year follow-up saying, okay, you're doing well, but I think we can do better. And we're going to see how your left eye is slipping from the green to the yellow. We're going to put you on the next strength dose, and we'll see you back in 3 months, and we'll see how you're doing. So again, it makes the conversation so easy.
I talked over you. I'm sorry. That growth rate stuff is fantastic, dude.
It really simplifies it so much. There's no more math. I mean, the screen comes up in my exam lane, show it to the mom and dad and saying, this is, we're doing good, we're not doing good, here's what we're going to do. We're going to do the same thing, or we're going to change. And it just speeds everything along, and it makes me feel very confident in my decision making.
Brilliant. How about this 8-year-old male?
So we got a young 8-year-old male who's already on 0.05% atropine for a year. You can see the steady increase in their axial length. Both eyes are in the red. This one to me is a no-brainer. This is your patient you just had, your Asian patient who is not being controlled by maximum low-dose atropine. This patient needs to be converted to either ortho-K or to multifocal soft lenses. In this case, we converted this patient to ortho-K, and we'll see. Hopefully, we'll get better control with that. But this is just an example where atropine works, but it doesn't work every time. And you need to watch, you need to measure, if you don't measure, you don't know.
Yes, if you don't measure, you don't know. All right, how about this 12-year-old female?
All right, so this was a patient we did fit with multifocal soft lenses. And after a year, this patient had a significant increase refractive error was only -1/4 in the right, -1/2 in the left increase in the year. But axial length was significant. So this is one of those patients, they're 12 years old, even though there's only a small change in refractive error, which didn't upset the parents, this upsetted me. I'm saying, wow, their eyes growing really fast, even though the refractive error is lagging behind. This is a case where I'm going to probably either add atropine or switch them to ortho-K, depending on the conversation, how it goes with the child and with the parent. So again, this is a case where you say, oh, it's only a 1/4 diopter or a 1/2 diopter, and they're 12 years old. It's not a lot. Well, it's not a lot, but their axial length is progressing, which means they're going to continue to progress refractively also. And again, the risk factors with axial length growth all go along with this. So this is a case where I'm going to talk to the parent in a much firmer way that we have to do something else. This is good, but not good enough. And here's the reason why. It's very easy to see. She should be down here, and she's in the yellow and red.
Brilliant, brilliant, brilliant.
I think we have 2 more cases.
These next couple cases?
Yeah, so the last 2 cases I think are ortho-K cases. This is a 16-year-old male. You see they're a moderate myope with mild astigmatism. You look at the treatment maps. Matt, would you agree these are pretty reasonable treatment maps? They look pretty good.
I think they look good. I would accept these.
And they're pretty, for a 16-year-old, you got a pretty large treatment zone. They're not complaining of glare at night, which I always hold my breath when they go from 15 to 16, they get their driver's permit. And now I'm like, well, what worked last year may not work this year, because now they're driving a car at night and they need to have really good quality vision at nighttime. But this child was not complaining of that. Let's take a look though at the next. And if we look at that growth curve, look at that. The ortho-K is working beautifully. Both eyes are in the green. We've got even a negative growth rate, which is within the standard deviation and error measurement of the machine. So basically we can say this line is flat. They're not getting worse. We don't need to do anything. The patient, if they're having no symptoms, we're going to keep them going. Just get them a new pair of lenses.
Perfect.
Simple and straightforward. I wish every patient was like this, and many are, but some are more like the next patient. Here's another ortho-K, a little bit younger, 13-year-old, a -3 with moderate cylinder in the right and a -6 with mild cylinder in the left. So a little bit of anisometropia, but look at those maps. Would you agree for a 13-year-old, those are pretty good looking maps?
Those are fire. I'd be happy with
I would
these.
normally be very happy with that. In fact, their uncorrected vision was 20/20 in both eyes. But let's take a look at the growth curves.
Oof.
We got a surprise in that right eye. The left eye looks pretty good. The growth curve is 0.16, not terrible. It's in the yellow, just barely in the yellow. But look at that right eye. That right eye is catching up to the left eye, even though refractively it hasn't. It is axial lengthwise. So this is a high-risk patient of progressing in that eye. So the question is, what do you do with this patient? What would you do, Matt?
Yeah, so if you're asking me, I think you've got really two options here. One of the options, it would be to readdress the treatment and see if you can get a smaller treatment zone, but that can be a problem unto itself as well, because if you push it too small, then you end up with a lot of haloing. The other side of the coin is we could add low dose atropine, 0.01%, 0.025%. How old was the child again?
13.
Okay, so we've got some time. So I would tend towards doing one of those two things. I would tend towards making that treatment zone smaller, although it looked pretty dang good like it was, or I would consider adding the 0.01%, or even better for me, 0.025% atropine, and see where it takes me.
So you read my mind, and I didn't tell you what I did, but I took the treatment zone down from 6.2 to 5.6.
Okay.
And was lucky enough that they didn't complain, and I added 0.025% atropine also. I don't know how well we're going to do. I need more data going forward, but that's exactly what we did just recently, and we'll know in a couple of months if we're hopefully slowing things down, particularly in that problematic right eye, and seeing if that refractive error starts to move.
The right eye's off to the races there.
Yeah.
I mean, that's significant.
All right, so we're running low on time. Why don't you talk about the protocol changes, and again, just reiterate really the importance of really, if you don't measure axial length, you really don't know, especially with ortho-K.
Measuring is absolutely humongous. You know, I think a lot of offices want to talk about myopia management, but they don't want to measure. If you're not measuring, how do you know what's happening, especially with your ortho-K patients? Because you know, if you can have axial length that's changing, and if you don't have any change in the refraction because you're, for lack of a better term, hiding it with ortho-K, you're not getting the results you need. If you're not screening kids, you absolutely should be screening kids. This says 5 to 15, really 5 to 18. We spoke about this earlier. Optical biometry is superior. In ease and accuracy compared to anything out there. And I think the Myopia Master is a lot easier than other instruments that I had tried before purchasing the Myopia Master. So it really did make it much easier for me. And then 4 times a year, 3 times a year, I think you need to be seeing patients way more than just twice a year. It needs to be 3 times a year. It needs to be 4 times a year. And I really enjoyed your protocol with having 2 doctor visits, but also having 2 data collection visits where they just come in and get Myopia Master, and your technician gets an auto refraction maybe. What do they do for that?
Yeah, they get an auto refraction, a Myopia Master, and an acuity check. So they'll just get uncorrected acuity check, and then they'll get an email from me the next day saying things are great, or you know what, I'd like to bring Johnny back in just to do one more thing, or we'll see you in 3 months, and at which point I'm going to see you. So there'll be a follow-up email on the tech visits that's not a doctor visit from me.
I think that's brilliant, and that's a place I'm going to be going in the future.
Excellent. Why don't we open it up? We've done a full hour. Why don't we open it up for some questions?
Perfect. Just wow, both of you. That was an amazing presentation, and I really enjoyed getting to learn just really how straightforward your thought process was and how you laid it all out. And I do have some questions ready for you. If any of you have any last minute questions, go ahead and submit them now into the text box. And if you missed any part of the webinar, or if there's anything you would like to go back and review, you will receive a link to the recording in the next week. The first question I'm actually going to answer: how do we get our software updated? Well, you can go ahead and give Oculus a call at 425-670-9977. They are open Monday through Friday, 8 a.m. through 8 p.m. Eastern, or 5 a.m. to 5 p.m. Pacific. And if you miss that, that information will also be included in the email. So moving on to other questions that have been asked. Do you bother to use cyclo before capturing autorefraction on your myopia management patients? Why or why not?
Well, I'll go first, and then I'll go really quick, Matt, then you tell me what you do. So I do a damp refraction. A damp refraction is something between a wet and a dry. So I use tropicamide. And so technically that's not a cycloplegic. It's a partial cycloplegic. So I'll answer the question is yes, I do, but I'm using 1% tropicamide, not 1% cyclogel on my follow-up visits. My first visit initially, I'll often use cyclogel, especially on the very young patients, especially on people that may have changed a large amount from year over year. But ongoing, I do my auto refraction measurements with a damp refraction with 1% tropicamide.
So I start out with 1% I'm sorry, 1% cyclogel when I first get started. And then after that, I'm looking at axial length, I'm looking at refraction. Oftentimes I'm either getting a damp refraction, or sometimes I'm just not even dilating their eyes at all on my follow-up visits. So I'm definitely starting out with a cyclorefraction, and I do a fair amount of refractions with 0.5% tropicamide. But sometimes I'm just using the refraction in their natural state combined with the axial length measurements.
Yeah, and some of it depends on the age of the patient. Some of it, obviously on the tech visit, they don't get any drops.
Yeah.
But on the doctor visit, they often will get something. And sometimes I will use 0.5%, especially if a kid has homework to do, and I'm not worried. Everything looks great, and I'm not changing their lenses. I'm not changing anything, and they're in the green, and everything is good. I won't torch the kid unnecessarily. I'm not going to get anything out of another 1/4 less minus on the auto refraction. So, but yeah, in general, I will do it. It sounds like Matt, we do about the same thing.
Yeah, it sounds like it as well.
Perfect. Matt, this question I think is going to be primarily towards you, though if you also want to hop in, Bill, I'd be very interested for your answer. Do you, and if so, how do you account for diurnal variation of the axial length?
Yeah, that's an interesting discussion because there are diurnal concerns. For me, I tend to measure at the same time for kids pretty much every time. So an example of this is I've been in the process of losing weight, and I've lost about 44, 45 pounds. I measure my weight on the same scale every day, right? I'm not changing scales. So if you're getting a axial length measurement of a child around 5 or 6 o'clock most days because they're after school, I get consistency, right? If I have a child in at 10 a.m. and a child in at 6 p.m., I may get diurnal variation due to the time of day. But most of my kids are coming in the same time slot consistently. It's not that often I'm getting kids at 8 in the morning on a Wednesday. Usually I'm getting them 5 or 6 o'clock in the evening. Bill, how do you handle diurnal
the same thing, the exact same thing. I mean, obviously there's those Columbus days where they're off of school where you throws your little curveball occasionally, a Saturday, but in general, they're all getting seen between 3 o'clock and 6 o'clock at night. So that 3-hour difference to me is not clinically significant.
Yeah, and to me, it's just like weighing yourself on a scale. If I went from my scale to somebody else's scale to somebody else's scale, I'm going to get a different weight, even if I'm doing it in an hour period of time, right? But as long as I'm getting the same measurement on my scale every day, I know where I'm at.
And like glaucoma, I very rarely will make a decision on 2 measurements anyway. I'm making it on multiple measurements, usually 3 or 4, before I'm doing something, at least changing something that I'm already doing. As far as starting the treatment, there's so many factors into starting the treatment. I'm not too worried about variations in the beginning. More so about should I change or should I stop or start something.
And is it the same concept as it is for glaucoma? If you have someone who comes in and your pressures are 34, you're going to think about doing something about that sooner
yeah, I mean, exactly.
than someone's pressures who are 21, right?
Right. The only thing is if I see something that dramatic with axial length in a 3-month period, I'll in my mind question whether the validity of, and I'll repeat measurements and I'll have them go back and just do it again. I want to make sure today is the same thing multiple times, just in case for whatever reason and I don't see variation, but to me to feel better, if I see a 0.4 millimeter change in 4 months, like that one case you show there, I'm going to put them back in front of that instrument just to make sure today is really right, because that's just atypical and unusual.
Yeah, in this particular case, we did do that child twice, just FYI.
Yeah, exactly.
Alrighty, I have one final question for you both. Alrighty, so this is a question digging into the growth charts and just kind of the concept behind the normative databases. How do you know that the normal growth is accurate? Perhaps some kids have higher than normal growth. So how do you account for that?
And I'll go first, and I'll just say, because there are thousands of normative data points in the database, again, I trust the large volume of data. Now, obviously, there are ethnicity, there's differences in risk factors. I mean, if the child is sitting on their phone playing games all night long, I mean, there's a lot of factors that go into my concern about the growth rate and things that are going on. But as far as just looking at the numbers, I trust the thousands of data points in the growth curves that I'm looking at in the growth control module. So now that I have that normative database, that concern of variations concern me less, and I'm just going to go by. I'm going to go by what the normative curves tell me, like we do in glaucoma, like we do in a lot of other conditions. I'm trusting the data, the massive data, instead of looking at just one point and one kid.
And that's where I'm at on the subject as well. That normative database is going to be a big factor there for me. And then on top of that, and I hate to use the glaucoma analogy so much, I feel like I'm belaboring a point, but if a person's got a pressure of 34, or a person has a very significant axial length measurement, and I know that's a true axial length measurement, I'm going to have to do something about that. I just can't sit on the sidelines and assume that's normal growth for that particular individual. Like, if it's that outside of norms, I'm going to be acting on it.
Yeah, it's really a matter of what you're going to act. What is your plan, and what are you going to do? You're going to intervene. It's just a matter of which intervention you're going to choose.
Yes, that's exactly right.
Good questions, Carver.
Perfect. Well, thank you, Bill. Thank you, Matt. I want to thank you both so much for your wonderful presentation tonight. And for all of you that have been in the audience listening this entire time, I just wanted to thank you all so much for your attendance tonight. I hope you have a wonderful evening. Bill, Matt, any final words?
No, I want to thank Matt again. Yeah, thanks for these great cases, Matt. I really appreciate it. Have a great evening, everybody.
Thank you, everyone.